Thank you, Mika and Claudette, for inviting me. And I have no financial interest in this matter. So I had a 70-year-old male. He had femto LASIK done 2013. Prior to the femto LASIK, he had refraction around -10 diopters, and he had cataract, grade 2, like nuclear cataract and cortical spice on both eyes. And on the left eye, he had some epiretinal membrane as well. He now uses multifocal spectacles. Here you can see the preoperative data, and he saw that the best corrected vision was 0.2 logmar, which is 0.8 at decimal, which we use here in Finland. He had already trouble with the cataract. The night vision has worsened. Also, he had glare from lights. He reads a lot, and he would like to do some Thai fishing flies again. And that was one of the reasons why we decided to go with the continuous IOL. Well, the challenges here were that, well, since he's had -10 diopters of ablation with LASIK, so he has induced positive spherical aberration, maybe even too much. He has some epiretinal membrane on the retina, and for me, I feel like the post-LASIK formulas aren't still quite as precise. So that's why I operate one eye at a time, starting with the non-dominant eye. And what to consider with the operation is that for him, near vision was really important. He wishes to be spectacle-free. EDOF would be maybe the safest bet, but it doesn't bring enough near vision with my experience. And trifocals would bring near vision, but it would also maybe risk more of higher order aberrations with the amount of ablation he's had. And the eye isn't, to be honest, isn't in a pristine condition. So that's why I use the Galaxy lens. So the patient that I'm operating today, I'm presenting to you, is a 70-year-old male with a history of LASIK surgery around 10 years ago, and the correction was about 10 diopters on both eyes. He has cataract on his both eyes. He has some epiretinal membrane on both eyes, but it doesn't affect the curvature of the fovea. And the K values that he has are around 39 diopters on both eyes. Since he has had prior like -10 diopters, his refraction, he really wishes to have as much of a spectacle independence as possible, but also the near vision is very important to him. He does understand the limitations of using a new lens that isn't a monofocal, but as I said, he really wishes to have as much of a spectacle independence as possible. So on the OCT you can see a small epiretinal membrane, but it doesn't affect as much for the fovea. Okay, so we have previously -10 diopters treated by LASIK, and now we have cataract surgery with a non-toric Galaxy lens. Okay, ja katse kohti valoja. So the patient looks straight into the beams. I'm going to do my side port over here. So puuduttavaa tippaa. And then we're going to use my drain that has some analgesic in it and also dilates the pupil a little bit more. And now the main tunnel. Ja vielä mä koskettelen sitä silmän pintaa. I usually puncture with the knife the capsular bag so that when I use the capsular rexis forceps, I don't need to do the puncture anymore. Nyt jos haluat lähteä liikenteeseen, niin pyri, että et lähde seuraamaan niitä. There we go. Nice round capsular rexis. Nyt saattaa valot sumentua. Now the hydrodissection. We rotate the nucleus, which we're trying to. Now we begin the phaco. Käännäkö vähän katsetta minua päin? So I usually clean the anterior part of the lens. Then I do the main groove. I use the paddle as my secondary instrument during the phaco. So one by one, I take them to the anterior chamber and emulsify all the pieces. Last one. Okay, so phaco is done. Time to remove the cortex. Try to always start with the cortex that are left in the under the tunnel, because those are the pesky ones to remove. I always try to go, when I get the suction, so straight into the middle, so it doesn't affect the zonules as much. There we go. Oh, that was a tough one, that one. Now polishing. As good of a polish as I can safely do. To say okay. Okay, yes, we'll take the lens, please. Yes. And then the OVD, suoja-ainetta tulee taas. Try not to overfill it. Katse kohti valoja. Now again, patient fixates to the lights and the lens comes. The RayOne platform has a nice nozzle, so I like implanting the lens. Comes nice and easy. Usually my trailing haptic is always over the iris plane, so at this point with the Zinski hook, I just rotate the trailing haptic as so. And then I leave a small opening to get rid of the visco. First, the side port, I hydrate it a little bit more, like so. Okay, so I go straight to under the lens and take care of the visco. Saattaa tuntua vähän venytystä, se kyllä loppuu tosi nopeasti, jos sellaista tuntuu. Slightly nice and easy, there we go. And usually at this point, I don't step on the gas immediately. Try to avoid like massive spikes of pressure. So easing my weight into 100% of vacuum. And I rotate the lens a couple of times, because at some point this rotation also clears some pesky remnants of the cortex, but there's none to be seen now. And then I rotate the lens basically so the haptics are on horizontal level. When the haptics are like this, the patients may not have as much of a negative dysphotopsia afterwards. And there you can see hopefully all the rings that the Galaxy has. And then we just basically hydrate all the main tunnel. The side port again. Intracameral antibiotics. And then we dry and check the pressure. And that's it. Thank you.
Okay, so it's been 3 days since the cataract surgery and the Galaxy implant. How do you feel in your own words that you see now with your left eye?
I have a feeling that I see pretty well. So it's more or less like before with lenses.
Have you experienced any differences between colors since you had cataract and now the cataract has been treated on the left eye?
Yes, there is a difference in color, especially with white color when we have white snow at the moment. So with my right eye it looks a little bit brownish, but with my left eye it's totally white.
Okay, and have you experienced any halos or so-called dysphotopsias, any starbursts between lights or anything like that?
No, not at all.
How would you describe your far and near vision now only with your left eye? Do you see well the near distance and the far distance?
Yes, I have a feeling that both are quite good at the moment.
Thank you.
Thank you, Ossi. The patient looks very, very happy. Why do you operate one eye at a time?
I only operate the one eye at a time if the patients have had prior laser ablation because, well, I use all the ESCRS calculations that we have, and for a virgin eye, they're especially good, very precise. But for the post-LASIK, post-PRK, it doesn't work as much, and there's much more of a differences between these calculations. So I want to start with the non-dominant eye, almost like a target practice, if you will, and then when they come for the first post-operative session, so I can then check whether or not the calculations were correct, and we can use the same calculations for the dominant eye, because if we only have to, I mean, my argument would be that it's best only to correct one eye if you don't have to correct both of the eyes. So it takes a long time, but the patients do understand it, and it's just my preference at the moment.
Okay. And we saw some macular pathology, and the patient had LASIK, -10 LASIK before. Why wouldn't you use an EDOF lens with a slight offset, like a blended vision?
Well, in my experience, patients who've had a lot of LASIK ablation, if they don't get the near vision, they're not as satisfied. Well, with the EDOF lens, obviously we can do the slight offset, but since I'm operating with the non-dominant eye, that would be the one is actually targeted to the near vision, but then they wouldn't see the far distance. And it was the previous session when I think it was Michelle Gunnar or someone who said that the ones, when they don't see the distance vision, they're not happy. So that's basically the reason that I'm using it. And well, the Galaxy lens, it's like a continuous, almost like a trifocal lens, but I'm actually using it almost like an EDOF lens. So it has the benefits of an EDOF, but it just comes with a lot more near vision.
Okay, thank you, Ossi. A lovely case.
Thank you.